kind of a combination of liver surgery and kind of discussing about different types of liver resections and the planning for liver surgery and liver tumors. And I'm going to touch upon lots of different kind of common and rare hepatic tumors as well. But I'm going to spend a bit more time on colorectal metastasis. Hopefully, it'll be interesting for colorectal trainees rather than upper GI trainees. So the first kind of about 5-6 slides is about liver in terms of the anatomy and planning for surgery, and what do you do when the volume of the liver is not enough? How do you assess how much liver is enough or not? And then we go into the liver tumors. We go basically touch upon the most common benign tumors, then a couple of pre-malignant, and then we'll go into in detail of primary liver tumors, and then we'll end up on discussing about secondary tumors or metastasis, you want to call it. So I don't know how much you know about liver, but it's the largest organ in the body. It's almost 1.2 to 2% of the total body mass. This is the only organ in the body which can regenerate. If not that capacity, that function, we wouldn't be doing anything what we are currently doing, i.e. liver surgery. And the interesting fact about liver is it has got dual blood supply. The only organ in the body has got dual blood supply is liver. It has got a portal venous supply and hepatic arterial supply. Who's going to tell me how much is the volume goes to the portal vein and hepatic artery per minute? Yeah, is there? Good. Okay, so all of you are paying attention and looking at the slides at least. So almost kind of 25% of the blood supply, a blood that goes to the heart, goes to the liver per minute. So that's roughly equates to 1.5 liters to 2 liters of blood per minute. 70% of that volume goes to the portal vein, 30% goes to the hepatic artery in terms of the volumes. But when you talk about the oxygenated blood supplied to the liver, it's reverse. So 30% of the oxygenated blood to the liver comes from the portal vein, 70% comes from the hepatic artery. That's why you need both hepatic artery and the portal vein. For any part of the liver to survive, it needs 5 things, okay? A portal venous supply, hepatic arterial supply, a biliary drainage, and hepatic venous drainage, 4, okay? So portal venous flow, hepatic arterial flow, hepatic venous outflow, and biliary outflow. Let's say, for example, you've damaged the right posterior sectoral duct. Nothing happens at that time because the arterial flow, venous flow is okay, venous outflow is okay, but there is no biliary drainage. What happens? The bile gets accumulated in that part of the segment of the liver, and then over a period of time, because of the pressure effect, the liver will slowly atrophy. Once it's atrophied, it will also it affects the blood supply as well, and it forms a nidus for infection. That's why if you have done a damage to one of the sectoral ducts, those patients could come back to you or to GP presenting with symptoms of cholangitis, and you wonder why. Is there anything related to the cholecystectomy you have done 5 years ago? Absolutely yes. That is because there's a damage done to one of the accessory ducts, and you either can treat it with the antibiotics, or if it's a hole of the right hemiliver or the left, you have to think about resection. So liver in that sense is really peculiar. The other peculiarity about liver is the anatomical variations. And I can tell you almost 20 to 30% of general population will have some sort of anatomical variation, okay? So if you look at the anatomy, you have the celiac artery coming from the aorta, then it divides into left gastric, splenic, and the common hepatic. Then the common hepatic divides into a gastroduodenal and proper hepatic. Proper hepatic divides into right, left, and sometimes you can also get a middle hepatic artery. I don't know how many are aware of that. There can be a middle hepatic branch supplying the segment 4 of the liver. Now, there are so many variations in the anatomy of the arterial system. So the common hepatic completely replaced and come from a superior mesenteric artery. So the other terminology you need to be aware of is replaced and accessory. Replaced means the whole artery is replaced coming from the SMA rather than coming from the celiac, and that is the sole blood supply in terms of the artery. There is no other accessory artery supplying the liver. For example, you can have an accessory right hepatic in addition to the main right hepatic. So the main right hepatic is coming from the celiac, and accessory is coming from the superior mesenteric artery. In that case, there are two arteries. That's why they're called accessory arteries. So the one behind the portal vein is always accessory or replaced, okay, because that is coming from the SMA. Replace means there's only one artery, and that is coming from the SMA, not from the celiac. So about 25% of us will have a anatomical variation in terms of the arterial anatomy. Then you need to think about the portal venous anatomical variations. The common anatomy is where you have the left and the right portal vein come and join together and form a common trunk, that is the portal vein. So if you look at this, as the left portal vein and the right portal vein and joining and form the main portal vein. Actually, it is from below. It's the jejunal branches, the ileal branches, they come all together, then form the superior mesenteric vein. Then superior mesenteric vein is joined by the splenic vein, and the inferior mesenteric vein then becomes the portal vein. Okay, so the vein always from below rather than from above. But just for the ease of kind of understanding, let's think that there's a left portal vein, the right portal vein, and there's a main portal vein. But there are lots of variations, and the two common variations are these, where the right divides into anterior and posterior and comes off separately and joins the left separately. So there is a trifurcation rather than a bifurcation like this. And the most dangerous anomaly is this, where the right anterior portal vein comes off and joins, or comes off or joins the left. So if you are doing the right hepatectomy, and if you are not aware of this anatomical variations, you can divide the whole vein here. Or if you are doing a left hepatectomy, and if you go up here, you could damage the portal vein supplying the right off of the liver. So that's the most dangerous anomaly. It happened here in this hospital. And luckily, you know, we managed and patients survived. And then the hepatic venous outflow, there are lots of variations. The classic teaching is that you have a right, a middle, and the left hepatic vein, 3 veins. Okay? But actually, in real life, there can be 2 right hepatic veins, 2 middle hepatic veins, there'll be 2 left hepatic veins. There are lots of variations. For HPB surgeons, it's very important, especially if you're doing a laparoscopic liver resection. It's all the more important than even an open operation, because if you do any mistake during laparoscopic liver resection, then it can be disaster, and controlling the bleeding can be, you know, quite challenging. So I rely quite heavily on intrapulmonary ultrasound scan to know the anatomy of these two, especially. Hepatic artery is a bit difficult because it's tiny compared to the portal vein, but these two anatomical variations is very, very important when I'm doing a lap liver resection. Then the biliary anatomy, which is not that important when you're doing liver resection, is more important when you're doing a cholecystectomy, actually, more than the liver resection. But there are lots of variations in the biliary anatomy as well. And the common one is the right and the left join together and form the single common hepatic duct. But the right anterior and posterior can join separately to the left and have a trifurcation. Right posterior can join the cystic duct insertion. Okay, so there are lots of variations, which we don't need to really go into that. And then other interesting fact about liver is the segmental anatomy. How many segments are there in the liver, which is already there? How many are there? 8 or 9? So it says 8 here, okay? But actually, if you think about 4 is divided into 4A, 4B, okay? So 1, 2, 3, 4A, 4B, 5, 6, 7, 8. So there are actually 9, okay? But the liver anatomy is highly complicated. There are apparently more than 20 segments in the liver. Okay, this segment, what we think is one segment, is actually has got further subsegments. Okay, that's why this is just a kind of a general outline. Think about that. There are total, you have 4 segments on the left, 4 segments on the right, and the caudate lobe is pretty much independent, and that is called segment 1. So when we say segment 1, it's always caudate lobe we are referring to. On the left side, the left hepatic vein divides the liver into an anterior. Let me go back to this. Sorry. Okay, let me make it try and make it really simple. So the liver is divided into 2 halves. Okay, the right and left, but it is not a 50-50 split. Okay, it is 60-40 split. So the right hemiliver is about 60% of the total liver volume. The left is about 40%. Is that clear? Okay. Each half of the liver is divided into two further halves. They are called sectors. Okay. So if you take the right and the left, what is the line of demarcation between the right and the left? It is the middle hepatic vein. A middle hepatic vein starts behind the cystic plate. And I hope you remember from my first talk that that's where the middle hepatic vein starts. If you breach the cystic plate, you can get into the middle hepatic vein, and stopping the bleeding from the middle hepatic vein can be a nightmare. There was one case I did where the registrar was doing very well and got to the middle hepatic vein here, and I took an hour to control the bleeding. And I can tell you, I've used every single method I know to control the bleeding, including, even though we're not supposed to argon as well. Okay, at the end we managed to control it, but it can be a nightmare because there is no muscle to contract to slow the bleeding. Okay, it's always opens up, closes, opens up, closes, and if you leave it, that's it. You lose the patient. Okay, so that's where the middle hepatic vein starts, and then it goes to the inferior vena cava, and anything to the right side of the patient is the right hemiliver. Left side of the middle hepatic vein is the left hemiliver, and then right hepatic vein divides the right half into an anterior sector and a posterior sector. Posterior sector is up because it's at the back. Okay, you won't be able to see it when you're doing a laparoscopy. It's all at the back. What divides that? That's the right hepatic vein. And the left side, the left hepatic vein divides, same thing, anterior and posterior. Anterior is segment 3 and 4. Posterior is segment 2. Is that clear so far? So two halves, two sectors. Each sector is divided into two segments. Okay, so the right anterior sector is divided into a superior segment because it's close to the diaphragm, and inferior segment because it's away from the diaphragm. Posterior sector, again, same thing, an inferior segment and a superior segment. Same thing on the left, a superior segment, inferior segment, superior segment, inferior segment, except that on the left, the anatomy, the nomenclature is slightly different. We'll come to that in a minute. Okay, so far so good. So there are 4 segments on the right, 4 segments on the left, because the 4 is divided into A, superior, B, inferior. Okay. To make our life easy, the left side, the nomenclature is slightly different. We use the term a medial sector and a lateral sector. Anything to the left of the falciform ligament is called left lateral sector or left lobe of the liver. Okay, that is the old nomenclature. But when we talk about left lobe, that we are referring to segment 2 and 3, which is also called left lateral sector, which includes anterior and posterior sector according to the original nomenclature, if you use the same nomenclature compared to the right side. Segment 4 is the medial sector, okay? And medial sector has got superior and inferior. So when we talk about right hemihepatectomy, we're talking about removing 5, 6, 7, and 8. By the way, we're just given the numbers just for the sake of easiness, really, to understand, to communicate. Okay. So that's right hepatectomy if you take that part of the liver. If you take off the segment 4, 2, and 3, that's left hepatectomy. If you take only 2 and 3, it's called left lateral sectionectomy. If you're taking only 4, that is called segment 4 resection. If you're taking 7 and 8, that is called right posterior section. And you can understand where the names come from, posterior section, because we are taking the posterior section, which is segment 6 and 7, it's called right posterior sectionectomy. It's not difficult. It's not complicated science. As long as you understand the 2 hemilivers, right and left, each hemiliver is divided into 2 further sectors, anterior and posterior. Each sector is divided into 2 further segments. Total 4 on the left, 4 on the right, and then a cardiac lobe, which is independent. Same thing in different colors, okay? And that's from the back. Now, when radiologist looks at the scan, okay, because that's what we are interested in. We are not interested in terms of when we're not operating the patient straight away. We wanted to know where the tumor is looking at the CT scan, okay? So when we talk about the segmental anatomy of the CT scan, anything above close to the hepatic vein, we are always talking about superior segments. So the superior segments are 2, 4A, and 7 and 8. Okay, so 7 posterior, 8 anterior, 4A, and then 2. So at the level of the hepatic veins. When it comes to the portal vein, then we are always talking about inferior segments. That is 3, 4B, 5, and 6. Okay. This is quite useful when I talk about the gallbladder bed resection and stuff. That's why just keep this in mind. Okay. Okay, so that's the anatomy of the liver. In terms of the types of liver resection, there are two. Again, we use two terms. One is non-anatomical and then anatomical. Anything which follows an anatomical plane is anatomical resection. Simple, straightforward. If you're taking segment 4, following an anatomical plane of segment 4, that is called segmental resection. If you don't follow the anatomy like this, there is a tumor up there. I've done intra-ultrasound scan and I marked it, and I just take this bit of the liver with the tumor. That is called non-anatomical. We should stop using the word wedge resection. Okay, wedge resection means you're really taking a wedge out. Wedging is not always a good thing. There's a high risk of you getting R1 resection. So we should really talk about non-anatomical, and you go in like a diamond shape and take out the same depth and the width of the base compared to the top. Now here, I've already divided the blood supply to the right hemiliver. You can see the difference in the color, and I'm marking the line in Cantley's line. That is the line of the middle hepatic vein. And I'm going to take the right hemiliver out, and that is called an anatomical operation. We've already gone through this. So that's the left hemi, right hemi. Okay, so what do I want to know as a surgeon before I plan liver resection? If somebody says, okay, some patient has got a colorectal metastasis, I need to plan. And this is what is quite challenging and complicated as an STD surgeon, because we have to plan a lot of things. It's not like, for example, there is a colonic tumor in the right colon, you're going to do right hemicolectomy. But liver, because of the segmental anatomy, you need to think about the inflow, outflow, lots of things. So a lot of things I want to know. First thing I want to know is liver resection feasible or not? Previously, we used to say if somebody has got multiple colorectal metastases, surgery is out of the question. Okay, one is multiple can be many, more than 2. It could be 2, 3, or 4. So it doesn't mean anything. Okay, then they can talk about bilobar. Okay, are there 1 and 2 on each side? Are there 2 one side, 1 on that side? Are there 3 or 4? Which lobes, which segments are affected? Again, I need to know. So first thing is, can I leave somebody with enough liver? Is the first question we ask. Okay, if the surgery is indicated, that is the first question. Doesn't matter the number, doesn't matter the size, doesn't matter where they are. Is liver resection is feasible? The next question we ask is liver normal? Because that will decide how much of liver I need to leave behind for that person to survive. What we call a future liver remnant. We use the word FLR. Okay, it is ideally we should use the term for functional liver remnant. That's what I want to actually use it for, but we usually say it's a future liver remnant, not necessarily whether that is functional to 100% extent or not. Okay. Then we need to know where is it, which segment of the liver. That will tell me, can I do a segmental resection or I need to do a right or left hemi. And then how many segments are involved? Again, that will tell me how much liver I need to take out. Then other questions, the size, the number of lesions, and relation to inflow, hepatic artery, portal vein, bile ducts, and relation to outflow, and relation to the gallbladder. Okay, those are the questions I need to answer before I say that, okay, that's fine. We are going to go ahead and do this operation. Okay, this is what we decide in MDT. If we don't decide this in MDT, we have a meeting on Monday morning. All 4 of us or 5 of us now, whoever is around, sit together with the CNS. One of us will be looking at the scans. One of us will be going through their letters and stuff. And one of them will be updating us their status in terms of the chemotherapy they're on. And then we plan the surgery pretty much on that day, not in the MDT. Okay, MDT is usually, is it operable or not? Is it the right thing to do for the patient or not? Okay, but think about all the things we need to think before we plan liver resection. Okay, so what is the aim of the surgery? And I've already mentioned in terms of assessment of for feasibility of liver resection. So what I'm aiming when I'm planning for liver resection is R0. That means complete resection, margin-free tumor. Okay, not R1, not R2. Sometimes we do accept R1 or not 2. If I have time, I'll go through it. If not, there are some exceptions where we can accept R1 resection, especially neuroendocrine tumor. If they're functional neuroendocrine tumor, it's called debulking operation to get the bulk of the tumor so that they can be controlled with the hormonal treatment. Okay. And then I mentioned about FLR. So basically, that considers two things. One is the volume of the liver. Two is the functional capacity of the liver. Okay, there is no good even if I leave 40% of the liver in terms of the volume, but actually it is not functioning very well. If they're alcoholics, they're morbidly obese, they're diabetic, they've got non-alcoholic fatty liver disease, or they're cirrhotic, that amount of the volume of the liver I'm going to leave behind is not enough. So I need to know the size and also the quality of the remnant liver. So the acceptable norm, okay, it is kind of, you could push the boundaries a little bit, not more than this really. So if you have a non-cirrhotic liver, that means normal liver, who is not alcoholic, not cirrhotic, non-alcoholic fatty liver disease, not diabetic, we can push the boundaries. I can take 80% of their liver, okay, leave them with 20%. That will be enough for them to survive while the liver is regenerating. If you had chemotherapy, then I can push the boundaries up to 30%. But if you are cirrhotic, 40% is the lowest we can accept it. That means the 40% of liver volume has to be there. Okay, so just give you an example. What do I mean by FLR? Let's say this example, you have a metastasis in the right hemiliver and metastasis in the left lateral sector. The only liver which will be left behind is segment 4. Okay, and that is not enough for that person to survive. Okay, so I need to think about increasing the volume of that liver. Another example, there is a tumor up here, there's a tumor up here. Again, I'm going to leave only just segment 4. That is not going to be enough. I need to think about how am I going to increase the volume of that liver. Another case, a congenital anomaly, there is no left hemiliver. Okay, there's no left lateral, sorry. Okay, only segment 4 and the rest of the off. That is the tumor. You'll need a right hemi. We'll be left with a small liver segment for that person to survive. Okay, this is an example. I thought I'm not going to share any stories, but I will share you a story. Okay, so this patient had neuroendocrine syndrome. Okay, neuroendocrine tumor with liver metastasis. A gym instructor, mid 40s. Okay, absolutely fit like anything. She was diagnosed with neuroendocrine tumor almost now 5-6 years ago. Okay, seen by oncologist, and oncologist never referred her for surgical option. And she was started on actretide and lanreotide. Her symptoms were getting okay, under control for a few years, and then they were out of control. And she got to a point she was completely wheelchair bound. She can't stand up. As soon as she stands up, she will get the Carcinoid syndrome symptoms: flushing, palpitations, sweating, tachycardia. She can't stand up, and that's it. And then somehow the oncologist thought about referring to us, and we saw the patient, and then we operated on her. And unfortunately, she had a cardiac arrest on the table. Okay, and I was still in my office waiting for the patient to be anesthetized, and then she had a cardiac arrest before the surgery. And when she had loads of actretide infusion, beta blockers, alpha blockers, you name it, but we managed to resect it. The next day, all the carcinoid syndrome symptoms gone, and she walked home. Came back 6 weeks later to have a small bowel resection. That's where the primary was, and she gave me actually a Zebra. Zebra is for the Net Foundation thing. So she stitched that, and it was so actually nice. So, but in her case, the FLR is very small, okay? But because this is not really constituting for any of the functional liver volume, you could manage to take that out, okay, without compromising the function. But we have to be careful. It has to be a kind of a tumor which we can take it out without compromising the liver function. Look at this one, massive tumor. That bit only the one which is going to be left behind. This one again, only that bit. So we have to think about how we're going to assess the volume of the liver. We can use a CT or MRI to know exactly the amount of liver we're going to leave them behind. Or you can do a 3D reconstruction. If there is a tumor in all these things, the only thing which we're going to leave behind is that. So what we can do to increase the volume of the liver is what we call a portal vein embolization, or a mini ALPS procedure, or an ALPS procedure. So I'm not going to touch upon the mini ALPS and ALPS. We'll touch upon the portal vein embolization. The idea is very simple, very, very kind of straightforward. Remember, I told you the portal vein supplies 70% of the blood to the liver. All the nutrients from the gut goes to the portal vein into the liver. And then basically that's a 60% and 40% split in terms of the blood volume to the livers. So you tie off the right portal vein. What happens to the rest of the blood from the portal vein? Will all go to the left. So the left will hypertrophy. Okay, and that's what we do. And you can do that in terms of the surgically, where you can go in and tie off the right portal vein, or radiologists can literally put a catheter, block it, and inject a glue, and the left portal vein can be, right portal vein can be embolized, and then the left will hypertrophy. Same patient, that's a portal vein embolization. The glue is horrible stuff when you operate, and it's a nightmare to do the dissection. And that's increasing the volume compared to that. You can assess that by CT or MRI. If you're happy with the amount of the liver, you can resect it. Okay, any questions so far? Yeah. Yes.
You just repeat it.
So the question is hepatic artery embolization, is portal vein embolization is better than hepatic artery embolization? Answer is yes, because I've just told you the amount of the blood volume that goes through the liver to the portal vein is much higher than hepatic artery. Two, all the nutrients goes through the portal vein rather than hepatic artery. Function is very difficult to assess because there's only one test which we can use to assess the liver function, which is still not available in the UK. I think only Newcastle has got it. I was trying to get it, but it's very expensive. Germans are using it quite left, right, and center because it's been developed by a German surgeon. And I'll tell you about that. But it takes about 2 to 6 weeks for the liver to hypertrophy. Yeah.
Any questions from Bath? Just whilst they're going to the mic, we had a question at the end of the previous session that I think we'd missed because they went. Why do you think lap ultrasound has not become more widespread / mainstream? What are the barriers to setting it up at service level?
So one is surgeons, lack of training, and the surgeons, again, just used to sending the patients to the gastroenterologist for ERCP, so that's an easy option. And always, we know, as a human nature, we always take the least resistance path. It's also a hassle in terms of getting a business case, writing a business case, and applying for a funding for the ultrasound scan. And last but not the least is training. They know there is nobody out there who can go and train, but that is not true anymore. We are around. Me and Stuart and Ian Finley are the three kind of key people, not only in the Southwest, probably in the country, who are actually doing. And we are doing, like Andres, part of Andres' research is to find out how many centers are using lap ultrasound scan. We got already the survey results we have not analyzed, but we want to make a change. We want to influence that, and we want more people to learn intra ultrasound scan so that you give the best treatment in one go to the patient. Yeah, absolutely. Yeah. Okay. Any other questions?
Sorry, again, Chrissy, anything in Bath? I think that's a no.
Okay. Right. I think we are going to overrun quite a lot into Mark Puckett. It may be handy actually for us to have a little bit longer presentation. Okay. So the liver tumors, this is going to be quite extensive, and if it's becoming boring, please stop me. Okay. And I'll really skim through reasonably kind of quickly. So the liver tumors, if anybody asks you in terms of the classification, you can divide into two: primary liver tumors and secondary liver tumors, or you can divide them into benign and malignant. Okay, and then benign can be divided into inflammatory and non-inflammatory. Like any usual classification, if anybody asks you a question about any tumors, it's the same thing. So the primary liver tumors, so our workload in terms of the liver resection workload, 20% of the workload comes from the primary liver tumors. And they can be either from the hepatocellular origin, that is hepatocellular carcinoma, or it could be from a cholangiocell, then it's a cholangiocarcinoma, or it could be from the gallbladder, which actually it's still part of the cholangio system. So it should be considered as a cholangiocarcinoma, but we use a different term, that's gallbladder cancer rather than cholangiocarcinoma. So that is 20% of our work. And then primary benign tumors of the liver, hemangiomas, cystic disease, and then focal nodular hyperplasia. I'll go into the details in more detail in a minute. Okay, and then primary pre-malignant tumors of the liver, you have adenomas and biliary cyst adenoma, and I'll talk about in detail about both these conditions because you really need to know, especially about adenomas, because you will encounter once you become a consultant. Doesn't matter whether you are upper GI, colorectal, or HPB. And then secondaries, 60% of our total work volume in terms of the liver resection comes from the secondaries, so mainly from the colorectal metastasis. Then about 10% of the work comes from the non-colorectal metastasis that can be from breast, ovarian, melanoma, kidney, nasopharyngeal cancers, all sorts of secondaries. Okay, so we'll go through the benign tumors now. Most of the benign tumors present with no symptoms, i.e. asymptomatic. So they are picked up on investigation done for completely a different reason. And most common reason, that is non-specific abdominal pain. Okay, and it is a pain for us sometimes. Okay, especially if they have hemangioma and they think all the pain is coming from the hemangioma. That can be a nightmare. But rarely they can actually have abdominal pain because of the tumors. In terms of the diagnosis, you have basically an ultrasound scan option, but most of the time we end up getting a CT and MRI. Almost inevitable that we will ask for an MRI scan for benign tumors, especially we are not sure what we're dealing with it. Okay. Very rarely we go for the liver biopsy, especially if the diagnosis is not certain, or not getting a diagnosis has got bigger implications in terms of planning for surgery. Then we'll go for biopsy. So the classification of the benign pre-malignant tumors, like the malignant tumors, so if it's a hepatocellular origin, then you have a focal nodular hyperplasia, adenoma, nodular regenerative hyperplasia, and then FNH-like lesions. I'm not going to touch upon these two, NRH and FNH-like lesions. You can forget about those two. We're going to just talk about these two. If it is coming from the cholangiocell origin, then you can have a biliary hematoma, also called von Meyenberg complexes, biliary duct adenoma, biliary cyst adenoma, also called this is also pre-malignant tumor. Biliary cyst. When I say biliary cyst, I'm referring to choledococele. Okay, we'll go a bit more details into choledococele. Then the last one is very rare. It's called intraductal papillary mucinous neoplasm of the bile duct, like intraductal papillary mucinous neoplasm of the pancreas. Exactly the same thing. If it occurs in the liver, that's the term you use. And then if it is a mesenchymal origin, hemangiomas, lipomas, angiomyolipoma. I'm going to talk about hemangiomas, not these two. Then inflammatory conditions, it can be abscess, hepatics, hydatid cysts, pseudotumors, pediosis, focal fatty change, heterotrophic tissue. The most common one, obviously, we all know abscess, then focal fatty change. These are the two common things. But I'm only going to touch upon the pseudotumors and pediosis. The reason for that is pseudotumors can mimic like a tumor, a proper malignant tumor. And patients had surgeries, extensive resections for pseudotumors because the surgeons were not aware of the condition. Okay, and luckily it's not common in the Europe, so hopefully we don't see that, but once in a while we do come across. Okay, so let's go back to the most common one, hemangioma, the most common tumor, if you want to use the word tumor, of the liver. What's the second most common? What's the second most common tumor of the liver? Benign one? No. Somebody says adenoma? No. FNH. Okay, it's a real pain for us. So if you do an ultrasound scan, that's how they look. I'm not going to go into the details of that because I think it will take all day for me to go into that one. Hopefully, I don't know whether Mark Puckett is going to cover. If not, I'm afraid you need to go to your radiologist and they'll tell you how they look. So they can be divided into giant hemangiomas and non-giant hemangiomas based on the size. Some people use 6 centimeters as a cutoff, and they use that cutoff to decide about they need to resect it or not. But for us, size is not the criteria. It's the symptoms is usually the criteria. The symptoms are they can have pressure symptoms. So if it's huge, pressing on the stomach, they can feel full, bloated, losing weight because they can't eat. Okay, that's one. Two, they can have what we call a consumptive coagulopathy or Hasselbalch. What is that, Charlie? Hasselbalch-Meritz. No, what's the name? Some name, fancy name, where there is a pooling of the blood. So they'll have low hemoglobin, low platelets. Okay, because of that, we consider for surgery. They can very rarely rupture, and they can also bleed. But these two complications, rupture and bleeding, is extremely, extremely rare. And there is some association between hormones. So estrogens tend to induce the growth. Okay, so if you are on the contraceptive pills, whether it's estrogen or a combined pill, they will grow in size. So one of the advice we give is stop the contraceptive pill if there is increase in the size of the hemangiomas on serial scans. Treatment, if it is only because of these 4 indications, not pain. Please do not refer anybody with a hemangioma. Doesn't matter even if it is more than 10 centimeter. If it just their symptom is pain, often that does not go away because usually they don't cause, unless it's so huge, they're dragging, stretching the liver capsule, that's fair enough. On the surgery wise, you can enucleate them where they're very well circumscribed lesions. You can enucleate it, or you do an anatomical resection, which we talked about. Sorry. So that's a radiology which we're not going to touch upon. Then the second most common is focal nodular hyperplasia. They're the second most common after hemangiomas. They're usually seen in females between 30 to 50 years of age. They're solitary, but they can be multiple as well. Almost up to 1/3 of the patients can have multiple FNH. And they are considered to be because of a hyperplastic reaction to an arterial malformation. And the classic sign of FNH on radiology, mostly on MRI, is the central fibrous scar. If you see a central fibrous scar, that is almost a pathognomonic of FNH. And I'll tell you this, FNH is benign. Please, please do not resect them and do not ever mention to the patient that they have a risk of malignant transformation. If it is a pure FNH, it is not a telangiectatic variant, which is actually an adenoma, they do not need surgery. That's all you need to know. FNH, benign, no malignant transformation, and no surveillance is indicated. Okay, hepatocellular adenomas. Now, I'll go into a bit more details about this hepatocellular adenoma, even though they are rare, but they are more common in females who are on contraceptive pills. That usually, because of the contraceptive pill, estrogen induces the growth, and then they can have adenomas. But they can also be seen in males. If you're on anabolic steroids, the male also are at a high risk of getting adenomas. They can be solitary, they can be multiple. Multiple are usually seen in people with glycogen storage disorders, tyrosonemias, diabetes, and usually multiple adenomas is an indication for liver transplantation because that will address the underlying congenital disorder, that is usually tyrosinemia or glycogen storage disorders. Now, there are 4 types in adenomas. I'm sure there'll be more types than 4, but so far what we know, this is called a Bordeaux classification. Bordeaux or Bordeaux, I think it's a place in France. I think that's where they've kind of come up first time around in terms of the classification. So they are divided into 4, an inflammatory type, which is the most common one, followed by HNF1A mutated. Don't ask me what HNF stands for. I should know, but I don't. Then the third one is beta-catenin, and fourth one is still unclassified because it does not have any classical features of other adenomas, but it is still is an adenoma. So if you look at the IHCA, that is the inflammatory subtype, is a high risk of malignant transformation. And that's why we need to know this classification, because we can decide which one needs to be operated, which one we can just observe. So if it is an inflammatory subtype, is malignant transformation is high, it usually needs surgery. So yesterday, one of our upper GI colleagues came into our office, basically saying that he has got this 20-year-old lady who admitted with a bit of a lower abdominal pain. Then they did a CT. She has got 10 centimeters tumor in the right hemiliver. And she has got a CRP of 150, high white count, with no sign or obvious source of infection. Almost certainly what she has got is this, because they have raised inflammatory markers. The name itself tells you, inflammatory HCA, okay? Then you have HCA, which is basically characterized by the downregulation of one of the fatty acid binding protein, okay? And it rarely leads to malignant progression. If we know this beforehand, we don't need to operate on them. That is the importance of this. Then obviously the unclassified, which does not have any of the characteristic features of the other one, but it's still an adenoma. And then the last one is the beta-catenin one. Again, there's a high risk of malignant transformation. So if we know this beforehand, we need to operate on that. These are the kind of MRI features. I'm not going to go into the details, but the differential diagnosis for adenoma is always between FNH and adenoma, and also between HCC and adenoma, especially if it's a well-differentiated HCC. It can look like an adenoma. So what is the treatment? We use the 5 centimeters as a cutoff. Less than 5 centimeters, you stop the contraceptive pills, they regress. You don't need to operate on them. You repeat the scan 6 months later. If they're obese, if they're alcoholics, diabetes, make sure that is all under control, and then repeat the scan. If it is more than 5 centimeters, not regressing on stopping on contraceptive pills, or if they're male patients on anabolic steroids, or even if not on anabolic steroids, male gender is a risk factor, so we operate on them. If there are multiple adenomas, I've already mentioned, that's an indication for liver transplantation. So the next one, we're going to touch upon the cholangiocellular origin tumors, bile duct adenoma, and biliary hematoma. If I just say that they are benign, but there can be a pain when we are operating on patients for something else. If you see them, you think, oh gosh, are these metastases? Especially if you're pancreatic tumor resection, planning for surgery, and then you go and see these on the surface of the liver, you get panic, gosh, there can be metastasis, then you send for the histology. If the pathology is not experienced, then they can get confused. That's the importance of these things. Bile duct adenoma and biliary hematoma, they are benign, usually incidental finding discovered during surgery. You don't need to do anything with them. Then biliary cystadenoma, these are pre-malignant ones, okay? And the clue, how do you know whether they're biliary cystadenomas are a simple cyst? If you look at the cyst, you have multiple septae, and sometimes you can have a solid nodule, papillary kind of projections inside the wall of the cyst. And that is biliary cystadenoma. That is not a simple cyst, because if it's a simple cyst, you don't need to do anything unless they're symptomatic. If it's a biliary cystadenoma, then you need to resect it. They're rare. Almost 1% of the hepatic cysts can be biliary cystadenomas. But if you look at the symptomatic cysts, about 5% of them are actually biliary cystadenoma. But most of them present on incidental investigation, or they can have a pain. They can also come up with jaundice if they're causing obstruction, or they can cause symptoms like hemangioma. Now, what is the treatment for this? The treatment is excision or enucleation, but more than enucleation, it's excision. Enucleation, the problem with enucleation is they can be connected to the bile ducts. Then you can't do an enucleation like hemangiomas. So most preferred treatment option is excision, a formal anatomical resection. If you don't do that, if you do a simple de-roofing of the liver cyst, where you take the roof of the liver, there is a high risk of it coming back again, and then that can become cancerous. 10 to 20% of them, they can turn into a biliary cystadenocarcinoma. Then the prognosis is really bad. And that's the importance of these lesions. Even though they're pre-malignant, you need to remove them. Now, we talked about bile duct cysts. So they're also called choledochoceles. You have 5 types. So the type 1, where there's a fusiform dilatation of the entire common hepatic duct, including the insertion of the cystic duct. Then type 2, you just have a side dilatation of the common bile duct. Type 3 is you have a choledococele just at the junction of the common hepatic duct with the pancreatic duct. And then you have type 4A, which is intrahepatic and extrahepatic. Type 4B is inside the under the duodenum or in the retropancreatic portion, close to that, and then in the common hepatic duct. Type 5 is purely intrahepatic, also called Caroli's disease. Okay. Now, how do they present? Most of them are incidental findings, or they can present with cholangitis, typical classic cholangitis, pride, abdominal pain, fever, and tenderness, deranged liver function test. But they can also present with this, 30 to 70% with pancreatitis. Do you know that? Okay, so they can. You need to think about pancreatitis. If you're not finding any cause, just be aware of the choledococele as well. Now, in terms of investigations, usual suspects, you do an ultrasound scan followed by MRCP. And if you're thinking of a tumor, then you may want to do a staging CT. Now, in terms of the risk of malignancy, that's why we're studying about this. Otherwise, we wouldn't be interested in knowing about choledococele. And unfortunately, the incidence of the cholangiocarcinoma, if you compare to general population who do not have choledococele, 20 to 30 times higher than general population in terms of the cholangiocarcinoma. That's why we need to know about it. The other interesting thing about choledococele is not only they are at a high risk of cholangiocarcinomas, but they're also high risk of getting other cancers like pancreatic cancer, like gallbladder cancer, and also malignancy inside the liver from the biliary epithelium. So it's very important for us to know about what's happening in terms of the other things in those patients. In terms of the risk of malignancy, it is pretty low in the first decade of life, but as you get older, the risk increases. So by the time you reach about 20 years, your risk of having a cholangiocarcinoma, if you have a choledococele, is 20% compared to general population. And unfortunately, it's the mean age is about 35 years, okay? And unfortunately, even after you remove it, you're not going to take the risk away completely because it's like a field change, okay? So if you remove the part which you can see, there is no guarantee that they're not going to get cancer somewhere else in the liver or rest of the bile duct. And 60% of the tumors are actually within the cyst rather than somewhere else. So what are the treatment options? If they have cholangitis, treat them with antibiotics. And if they need surgery, you're going to excise them and reconstruct with the hepatococcygeostomy. So type 1 and type 3, excision hepatococcygeostomy. If it's a choledococele at the junction of the pancreatic duct with the bile duct, you can do a ERCP and sphincterotomy, relieve the pressure and follow them up. But that's basically type 4A and 4B is basically excision followed by Roux-en-Y hepatococcygeostomy. If it's 5, type 5, where it's intrahepatic, you go for the transplantation. And then you survey them after that with MRCPs because you have not taken the whole liver out and whole of the bile duct. So I'll briefly touch up on the pseudotumors. The reason why I wanted to discuss about this is it's common in non-European population. It can mimic like a tumor. They can be quite aggressive, but they do not have any malignant potential. So you do not need to resect them. If you put them on steroids, usually they resolve and you don't need to operate them. They can present with all the constitutional symptoms like fever, pain, high CRP, high white count because they're pseudo. They're actually quite common in the lung. So it's the same variant of the lung pseudotumor. Ileosis is basically liver is filled with lots of sacs, which is filled with blood, okay? And it can cause fibrosis and obviously cirrhosis at a later date. And usually there is an underlying cause for ileosis. Either they are on anabolic steroids or infection, severe tuberculosis, and some of the malignancies can also have associated ileosis. So again, the treatment is not surgery, but just treat the cause, whatever it's causing. What shall we do time-wise? Mark? Are you sure? Yes? Yeah.
So we're just going to address a couple of questions. So the first one is adenoma type diagnosed by histology only, or are there any other markers?
So histology, just remember this, okay? We used to think histology is the gold standard, okay? But that is not true for most of the liver tumors. Even we take the whole tumor out and give it to them, sometimes they can still struggle in terms of telling us a diagnosis, whether it's adenoma or FNA, okay? But they usually have a classic MRI characteristics, and the radiologist can tell us whether it's adenoma or not, but sometimes it can be confusing even for them. There are no specific adenoma features on the radiology, okay? There are some, but not 100% specific. So if it is not very clear, we do go for a biopsy. If it helps, if it helps. If it doesn't help, then we may have to follow up. And if there's increase in the size, then we need to go for resection.
Ursula has said, I presume that it says bile duct cyst in adults because it's much different for presentation in neonates and children. Do we need to know about presentation in neonates and children?
I'm not going to talk about that, I'm afraid.
From the exam point of view, I don't think you really need to know about neonates.
No.
I'm sure nothing came up.
Yeah.
Other than
Unless you're
pediatric
doing a
liver
pediatric
transplant for
surgery.
Caroli's, but
Are you okay so far? Yeah, shall I carry on? Okay, good. Right, so we're now going to concentrate on the malignant tumors of the liver. And one of the most common primary liver tumor is HCC. And unfortunately, it is almost 90% of the primary liver tumors are HCC. It's the sixth most common cancer. What are the risk factors for HCC? I've already mentioned that. Cirrhosis. Cirrhosis because of alcohol, hepatitis B, C, whatever the cause of cirrhosis, that increases the risk of having a primary hepatocellular carcinoma. But I'll mention one thing is non-alcoholic fatty liver disease. The incidence of HCC in Europe and US is going up, not because of the hepatitis B or hepatitis C, but because of the obesity. The fatty liver disease is a risk factor. And the interesting factor about non-alcoholic fatty liver disease is that you don't have to reach the stage of cirrhosis before you get HCC. Okay, so you have non-alcoholic fatty liver disease, then you have non-alcoholic steatohepatitis, that is the next stage, then you have fibrosis, then cirrhosis. So the HCC can happen before you get to the stage of cirrhosis. And that's why it's very important when you see a patient with fatty liver on ultrasound scan, please don't think that they're going to put a complaint if you say that they are obese, they need to lose weight. No, you need to tell them. I think you're duty bound to tell them that they have to lose weight because it's reversible condition. But once you get to the stage of fibrosis, it is not reversible. Okay, so that's the importance of that. You can also get HCC without cirrhosis in patients with hepatitis B. Okay, so those are the kind of two exceptions where you don't have to have cirrhosis to have HCC. Now, for example, if you are cirrhotic, you are under screening surveillance program where you're getting an ultrasound scan plus minus alpha fetoprotein. Okay, and then you can see there are kind of three scenarios here. So you identified a nodule which is more than 10 millimeter, and AFP is raised, suggesting that this is most likely HCC. Then what do? You go for a multiphasic CT plus minus MRI to confirm the ultrasound scan findings. Okay, that either will confirm that there is no tumor or there is a definite HCC. It's not definite, but not also benign, or definitely benign. If there is no tumor, they go back to the surveillance, which is 6 monthly ultrasound scan and AFP. Okay. If there's a definitely HCC, they follow the path of HCC, which we'll go into in more detail in a minute. If it's not definitely HCC or not benign, then you need to discuss an MDT and decide about whether you need to do a biopsy or not. If it's benign, go back to 6 months, the surveillance. If it is less than a centimeter, you need to repeat the scan every 3 to 6 months. If it is negative on ultrasound scan, then every 6 months AFP and ultrasound scan. That is a surveillance. So if they are definitely malignant or not malignant, not benign, they go to the MDT. And in the MDT, you're going to go through all this. You assess their liver function test, look at their child's Q status. Are the child's A, B, C? Are they got any signs of portal hypertension? Where is the tumor? Is there a vascular involvement? The number of lesions, the size of the lesions, all those things, because you need to decide what is the best treatment option for them. Okay. Let's say, for example, based on all these things, then you have 4 categories. One is patients have potentially resectable or transplantable tumor, and they're also operable because of their performance status. So radiologically, they are resectable or transplantable. Physiologically, they're also fit. Then the second group is unresectable. Doesn't matter whether they're fit or not, they have got unresectable tumor. Then the third one is they're inoperable because of their performance status, not because of the radiology, because many of the comorbidities. And then you have a metastatic disease. So then you think about the options. What are the options? Options are surgery. Again, I told you in the beginning, life of a surgeon should be very simple. Okay? You need to make it easy if you can, and it's not complicated. If anybody trying to make complicated, they don't know how to kind of break it down and explain it to you. Simple options. You have surgery, transplantation, okay, transarterial chemoembolization, ablation, and chemotherapy. So 5 options you have, or no treatment. 6 options. Okay. So when do you go for surgery? Indications for surgery or transplant are exactly the same. Okay, the only difference is depends on the child's Pew status. Okay, so in terms of the resection, tumor of any size, child say, absence of portal hypertension, no macrovascular invasion, no extrahepatic disease, you go for surgery. If you have unlimited supply of organs, okay, then you go for transplantation. What are the other indications apart from unlimited supply of the organs? Single tumor less than 5 centimeters, 2 to 3 tumors of 3 centimeters or less, no extrahepatic disease, no macrovascular involvement. And also child's B go into that. Signs of portal hypertension will also go into under that criteria. So they go for transplantation. Is that clear? So if it's a resectable, fit patient, they fit into the resection criteria, go for resection. If they have child's B, portal hypertension, even if they fit into the resection criteria, they go into the liver transplantation. Okay, there's a waiting time for liver transplantation. How do you buy time? Because there's no guarantee that the tumor is not going to progress while you're waiting for liver transplantation. Then you think about this, that is a transarterial chemoembolization, which is a local regional treatment. It is not curative. It is simply a holding measure. What do? You cannulate the hepatic artery through the femoral artery or radial, usually femoral artery, and go and inject the Lepidol and then the chemoembolizing agent, usually a chemotherapeutic drug and Lepidol. And that takes up the tumor, only tumor. It's a very selective cannulation of that branch. And as I said, it's a local regional treatment. It's not curative. If you have decompensated liver disease, you can't do that because that will take the hepatic arterial blood supply. The liver will decompensate. They go into liver failure. We can't do that. Microwave ablation is usually for a solitary tumors less than 3 centimeters. Okay, even if they are fit, if it is under 3 centimeters, the survival benefit of surgery versus ablation is pretty similar. So you can go for the ablation that's the least invasive one. The sorafenib and lenavatinib, lenavatinib is the most recent drug approved by FDA in 2018. That is preferable over sorafenib if it is available. I'm not going to talk about bevacizumab, atezolizumab. Sorafenib, so for the people who are going for exam, sorafenib is a multi-kinase inhibitor. It inhibits lots of kinases. And there were 2 trials conducted in Asia. One is called SHARP trial, and that one is called Asia Pacific trial. Both trials have compared sorafenib to a placebo. And they looked at, obviously, the median survival and overall survival. So if you look at the median overall survival, around 11 months in the sorafenib arm compared to 8 months. So there is about a 3 months difference. And if you look at the 1-year survival, almost 10% difference between the placebo group and the sorafenib group. Okay, so based on that evidence, sorafenib became part of the treatment algorithm for HCC for unresectable patients. But usually the benefit is in only patients with child's A and B, not in child's Pew C. Even in child's B, it is not as good as child's A. That means the worse their liver, the prognosis is much worse. They die because of the cirrhosis, not because of their HCC. Okay. Then the second one is lenavatinib, which is the most recent drug, and it inhibits lots of growth factors, but mainly VEGF, vascular endothelial growth factor, fibroblastic growth factor, and platelet growth factor. And the trial which was done on this is REFLECT trial. It's compared sorafenib versus lenavatinib, and it is actually much better in terms of, if you look at the overall survival, 14 months versus 12 months. And now it is the first line of drug in US. In UK, I'm not still sure whether that is actually available or being used. Again, I can stop there and we can let Mark Puckett to carry on. I think we should stop there because there is a lot more to go through, which I won't be able to finish. Yeah. Okay, any questions, guy?
Or this is the other okay? So how to catch the correct test without knowing that? Okay. So first off, it has nothing to do with regulation. Okay. You tell me where this is nothing to do with the course. Okay. This is to see how people are regulated. Can you see anything in there? Couple of them. Can you see anything abnormal? Peripheral nodule. Have you seen this before? Okay. So this is. Okay. Okay, so this was published in an American journal. Okay, this was published in an American journal. Okay, and this is all about perception. Okay, and understanding that things are a lot more complicated than they look. Okay, there's a dancing gorilla. Okay, can you see that gorilla? And that was on the CT, and they showed it to loads of radiologists, and they missed it. Okay, so you need to look more than you think. Okay. There's a dancing gorilla, okay? So why are CT protocols important? When I started radiology, we used to hand inject. This thing was steam driven and it was very slow, and you got one protocol. But now, this scanner here can scan a heart in 1 second, okay? It can do a body in a couple of seconds. So now the scanner's moving quicker than the contrast can. So it's a lot more complicated, okay? We've got a lot more options we can do. And there's different things with timing, volume, rate of contrast, okay? So the CT protocol is actually really important, and you might think really boring. And when you come to see us and say, can I have a test? And we just sort of get exasperated. The reason is, it's really important to know what you're looking for, okay? So what are you trying to diagnose, okay? Because my analogy is, if you're going into the Atlantic and you throw a tiny net in, the chances of catching a fish are very low. If you go to a pond with a big net and throw it in, you're going to catch a fish, aren't you? And it's the same with imaging. Okay, so more specific the question, more specific the protocol we can do, and more specific the answer, hopefully. And we aren't trying to be difficult. Honestly, we are doing it for your good and the patient's good. We're not just difficult individuals. Okay? So this is very boring, okay? Do you guys know about evidence-based medicine? Yeah? So I was actually very lucky or unlucky. I got involved right at the beginning of this when I was sort of a junior doctor. It's been around for quite a while. But it's really important, okay, actually. So pre-test probability is crucial to what you're doing. So what is it? You're trying to decide what that patient has before you do the test, which sounds bonkers. But if you don't have that pre-test probability, you won't get a good test. So the results are very, very difficult to interpret. And then sometimes, is the test worth doing at all? Okay. The last one hasn't got much to do with radiology. So rather than going abdominal pain chronic cause, you'll get a CT where I've been a junior doctor, you get reports from radiologists, they sit on the fence, okay? They won't commit to anything because the question is abdominal pain query cause, okay? Much as it's frustrating, if you can get specific information in the clinical information, we can do some funky things. So, and it really depends on what you're looking at, okay? What are you looking at? Esophagus, stomach, small bowel, colon, hepatobiliary, pancreas, separate really actually, urological, trauma, or GI bleeds. So we can do different things with different contrasts at different timings. And it's actually very complicated, okay? So when the radiologist, we're trying to decide what to do, we think about how much volume of contrast, how fast we're going to put it in, the concentration, bolus tracking. Does anyone know what that is? Ever even thought about that? Excellent. And it keeps doing that until it hits a threshold and then it triggers. Split bolus. You would all know what split bolus is, but you haven't been aware of it. Who's seen trauma CTs? Only one person. So you guys don't do any trauma. So you would have all seen split bolus. Split bolus is we use it in trauma, and we inject a small amount of contrast, and then a few seconds later we inject some more contrast. So that when we do the CT, you've got arterial and portal venous in the same phase. Okay, it gives us more information. To oral contrast, do we give it? When should we give it? is it positive? Is it negative? By positive, we mean sort of an iodine-based or watery barium, or do we give water negative contrast? Rectal contrast, yes or no? Bladder contrast, yes or no? Do we lay them prone? Do we lay them supine? Okay, so very boring graph, okay? So this is when we're injecting contrast. So the aorta has a peak at around 12 to 30 seconds. The vein has about 60 seconds, and then the liver peak is a bit slower and not so high. And we're so fast now, if we just scan normally, we will get through everything too quickly, and we'll have the green one, the early arterial, okay? And then that's, I'll explain, not particularly useful for a lot of things. So we need to be a little bit slower, the blue lines, okay? And that is the late arterial, and then the blue phase is the portal venous, okay? So that's all the phases of contrast. So that's probably more than you even sort of thought or even bothered to worry about when you just look at the CT report. But this is what's going at the front end of your CT report, okay? So pre-contrast is actually quite important. Is there calcification? You talked about TACE in the series before. Lopidol, you can get staining from that. So if it's in the liver, how do we know that that's enhancement, or how do we know that's Lopidol? How do we know it's calcification? So we need a pre-contrast, okay? HCCs have fat. If you see fat in a liver tumor, is 99% it's a HCC, okay? And then for arterial, intramural hematoma, have you ever heard of that? Have you done vascular? Okay, have you seen type A dissections? Okay, type A dissections, the intramural hematoma is actually when the space is filled with hematoma, not flowing blood. So you just get a rim, and it's quite, if you don't do a pre-contrast, you'll miss it, okay? So this is on your left, okay, that's a gallstone, all right? That's pancreatic calcification, and that's vascular calcification, okay? So this is an arterial phase, as you can see, contrasting there, and you can see that it's high attenuation. Do we know it's calcification? We don't, you can't be certain, okay? But on the pre-contrast, there's nothing there, okay? On the portal venous, it's there. Who fancies himself as a radiologist? No? Someone must. You guys must think it. You're mouthing at him, Andrew. You don't want to be on camera or something, is that? Yeah, exactly. Yeah, peripheral nodule enhancement that's progressive, okay? But that is a calcification in a met. So if you didn't do the pre-contrast, you can see that is not so dissimilar to that. So pre-contrast is really important. Okay, so early arterial, that's 15 to 20 seconds. It's mainly just in the arteries. And as a regional centre, that's our main issue. A lot of CTs, they're too early, and they're not very good for liver tumours. Okay, it's mainly arterial anatomy or arterial trauma. Okay, so this is a trauma study, big pericardial effusion. Can anyone spot the abnormality? So when you said you'd done trauma, hadn't you? That's the ascending aorta. Should your ascending aorta look like that? No. So there's a type A dissection there. Okay. So this is someone with GI bleeding. This is the pre. Okay. And this is the arterial. And you see that's the bleeding point there, and the portal venous getting slightly bigger. Okay. This is arterial phase, because you see it's really concentrated contrast in the aorta. Stuff in the stomach, this lump here, you see a dot gets bigger. That's a bleeding gastric tumour, because you obviously all spotted the met there from the gastric tumour, okay? So late arterial, really important phase, okay? So this is the phase where we pick up all the different, a lot of hypervascular tumours, a lot of them, errors are made, you say you can't see it because of the studies being performed in the early arterial. But basically, all those hypervascular tumours are present in those organs, okay? and it's about 20 to 30 seconds. So how do we know that that's a good phase? So this is too early, okay? So you've got contrast in the aorta, the portal vein, you can't see. Late arterial, you should be able to see the portal vein. You see the portal vein? So the bottom one's a really good one. Okay, so this was a case of a couple of weeks, well, a couple of months ago now. So patient had this CT, no METs, and for some reason we weren't convinced about it, and we repeated it. So this was the late arterial. You can see contrast in the portal veins. This is the same patient, okay? I've slightly changed the windows a bit so you can see, but you can see all the hypervascular METs. Same patient. So if you get the phase, you might assume you can see it wherever you don't. Okay, so this is a small bowel tumor. So this patient had this study, couldn't see anything, okay? The symptoms were of a NET, so we did a CT angiography. So again, the right protocol. The question came back more specific to a NET. So they had oral contrast, and there's the tumor, it's the enhancing, and those are the lymph nodes. If you don't do the right protocol, you get a garbage scan and we give you a garbage answer, okay? And it's not radiology being crap. That's the limitation of the study. Portal venous phase, that's what everyone knows. That's when you ask for an abdo-pelvis, this is what you get. So 60 to 80 seconds, and this is the hypervascular liver lesions, okay? So how can you say it's portal venous when you next look? Make sure there's contrast in the hepatic veins, okay? So you've all seen things like this. So vote, who thinks that's a MET? One from that, okay? There's a little confusion. Confusion from that. Okay, abscess. A lot of you really, you'll be good radiologists. You're sitting on the fence. I like it. So real case, I saw this. Made sure I thought it looked like an abscess. And you see a perianal fistula. Okay, so you've got to. It's really important to look at all the scan. Turned out when I reported it, they went, oh yeah, he's diabetic. Nephrogenic phase. I won't talk a lot about this. This is mainly urological. This is for looking for urological tumours. But it's very specific. It is later than portal venous. It's about 100 seconds, okay, and it's really good for picking up RCCs. Okay, equilibrium phase. I'm a GI radiologist, more interested in this. 3 minutes is sort of fairly specific, actually, and it's good for washout of hypervascular tumours like HCC and stuff. So arterial phase, you can see it enhancing. Portal venous, difficult to see. 3 minute, you can see it much clearer. So hemangioma expert. Is that a hemangioma? Don't know. It's already washed out, so it's a HCC. Okay, that's a typical HCC. Okay, so there's a lot of writing on this. Okay, so basically, this study here was done too early. So there's a nodule that I've analysed, and you can see that the 3 minute phase is fairly accurate, and actually it's washed out. So although the arterial phase is not good enough, the 3 minute phase has saved them and showed that it is washing out. So this is residual tumour following TACE. Okay, delayed phase. Okay, so this is sort of after 3 minutes. This is for urograms, okay, and for sort of very fibrotic lesions. Okay, so this is a urogram. So this is done supine initially, and then you flip them and it fills, and you get a nice urogram. Yeah. Yeah. No, you don't need it for renal trauma. Just portal venous is fine. Okay, contrast options. So you can put it down the esophagus, rectally, in the bladder. Okay, so true story. This patient was, I think, from Troy, had a recurrent pleural effusion, came to us. We didn't really know why they kept having a pleural effusion. Kept getting CT, kept showing the empyema. and then someone sort of twigged that maybe we should put some contrast in the esophagus, and then you can see there's contrast in there. Okay, so there's a esophageal leak which is dry. So again, this patient went on for several weeks before we actually did this. Okay, so again, if there's query about esophageal leak or perforation or trauma, do the right study, and we get a good answer. This is a pouch. Oh, this is a pouch. Okay, bit of fluid there. Doesn't look very happy. Patient non-specifically unwell, but we're not really getting over with the answer. So we put some contrast in the pouch, and then you can see there's a leak, and that's the cause of why they're septic. Trauma. Okay, that doesn't look very good. All right, that's the bladder. That's a lot of stuff around the bladder. Okay, but we don't really know what's going on. So we put some contrast in, and you can see all this stuff outside, but it's not free flowing. So does anyone know what type of perforation that is? You doing urology? Who's doing vivas in the exam? Do you have vivas for your exam? Oh, do you not have fluid? Oh, okay. So this is extraperitoneal, it's contained. So you can have extra and intraperitoneal perforation of the bladder. Lucky you haven't got it in your vivas. No, this is slightly more complicated. This is an intra and extra. Okay. This is just showing you the extraperitoneal component. Okay. So this is the split bolus that I told you about. Okay. So this is was a lady versus a car, and that's active hemorrhage. Okay, a split in the spleen. So you can see you've got arterial enhancement, but you've got normal portal venous enhancement. This is man versus knife. Okay, he lost. There's active blood there. There's a little bubble of gas, but you've got portal venous, so you've got good demonstration of anatomy. Don't forget about CT colon. Okay, if you want to see a polyp, you can see what you can't see it normally, but you put air in there and you get some really good pictures. Okay. So when we try and vet, those are all the things. When you ask for an abdo-pelvis, all those things are going through our minds just for abdo-pelvis. Okay. So being specific with your question will enable us to be specific with the test. So you, with your pre-test probability, will get a much better chance of getting the right answer. Okay. So those are just one test for esophagus, query perforation. That's the protocol. Those are all different protocols, and that's not esophageal cancer. And likewise, all that list of different, those are all different protocols. Okay, everyone gets slightly a triple phase liver. That seems to be what everyone obsesses with. But you know, there are other options available. Okay. Okay. Any questions? Other than I've got a question. Okay, we've all not been able to go away on holiday. Okay. Does anyone recognise that? And you are Southwest trainees. No, this is South Devon. So that's the second most expensive property in the UK. That's Salcombe. Okay, and this is East Portsmouth. You could be anywhere, couldn't you? So it doesn't matter that we've got COVID, guys. Yeah. It's better not to demand the from this. I want you to see what's going through our minds when you're coming to us. So we're trying to work out so we can get the best test. So if you're query leaking rectal, that's perfect because we can do the perfect test for that. Whereas if you just say, you know, anterior resection 3 days ago, unwell, you won't get rectal contrast because we're not going to unnecessarily do things we shouldn't do. No, generally, actually, it's at the point at which you're asking for it, or we're vetting it. MGTs, sometimes the liver stuff is because it's not done, so we can diagnose the issue. But yeah. Yeah, it's I mean that is a difficult balance, because we're trying to balance a resource that's limited. So if the patient's really ill, and they will probably do the most sort of non-specific protocol, but then as a consequence of that, you're the next morning going around, well, there's a bit of free fluid, the small bowel's a bit edematous, the lactate's slightly elevated, we're not really sure if it's, so it's quite difficult to get sometimes the answers from it. So there might be quite junior, so they might not know what you could do. It's a balance between what has to be done or what can wait. Yeah. Well, okay, this could turn into a very long debate, okay? But yeah, I mean, that's a difficult one, because you seeing the patient, you're the surgeon, okay? So I would hope that you've put your hand on quite a few bellies and you've opened quite a few bellies. Whereas you might have an F2 in ENT who's never seen a surgical abdomen, okay? And you're telling them to get a CT of an abdomen and pelvis. And I can tell you from quite a lot of experience that we do this, and sometimes quite often it's the wrong test. Quite often you go there and see them afterwards and go, oh, it's cholecystitis, they needed an ultrasound. But you won't ever go, actually, I was the wrong test, never mind, we got the cholecystitis from the CT. You didn't need the CT. So when we're saying, it's all about pre-test probability, because you're using your knowledge and experience. When you're examining the patient and you're looking at the films, the abdo film, you're looking at the blood test, that you are narrowing down that pre-test probability. So therefore, that the test that you are then asking for is much more accurate than just this scanogram. There was a joke of a surgeon when I was a gyn doctor here 20 years ago. A patient came by SAU, and the surgeon went, oh, just get a CT on this patient. Didn't even touch the patient. And actually, you're dumbing down your intellect and your ability if you just say, get a CT, because you're not narrowing down any diagnosis at all if you're doing a broad test. Because actually what I've shown you, we could probably nearly do every one of those things on every individual patient. We can get them drinking, put contrast at the bottom, put contrast in their bladder. We can give them 150 mils of contrast. We could literally get rid of everything, and then I can put a couple of lines on the tummy and say, do the lap chole here, please. So it's really, it is you've sort of hit one of my bugbears, actually, is my guess. So it is really important that you do look at the patient properly before requesting a test. It's not a full blood count. Sorry, you've slightly. Yeah. Okay. I think that is just something. Yeah, I think that's something to do with the protocol. That's not as in the level of referral. That's not. Yeah, I mean that's sort of slightly, yeah. So, yeah. So the IV.
So the question is there a downside to IV or oral contrast, or together, as in at the same time?
Sometimes there is, because if you're looking, again, it's a question. If you're looking for a bleeding point and you've given them liquid iodine to drink, you're not going to see a bleeding point. So you've got to make sure that you're not nullifying the answer by covering it up with oral contrast. And IV contrast, the main thing is renal function. Okay, it is a real thing, impairment. There's some nephrologists are really good and they're on board with it. And if you match, I'm not saying long-term impairment, but you match the renal function of a lot of your patients that have had IV contrast. Just do it. Just do it for the next 3 weeks. Look at their renal function after they've had a CT. I will guarantee the vast majority will have some impairment to some degree. I'm not saying that they're going to renal failure, but they will have some renal impairment. So IV contrast, the real thing, what I say is very much it is life. And if, it's a balance of risk. If their EGFR is 25, but you need contrast to see if they've got small bowel ischemia, they've got to have contrast. It's unfortunate, but it's the way it is.
So I know the renal team here have a protocol with sort of, I mean, that's possibly more in the elective setting, but for sort of pre and post CT hydration. So we do sometimes bring patients in for IV fluids sort of 4 hours before and 4 hours afterwards.
In emergency, you just have to.
And they sometimes stop some of their other sort of renotoxic medicines, but that's obviously an elective setting.
Yeah. In the emergency setting, it's just to be aware that the EGFR is impaired and you need to keep an eye on the renal function. They may need renal support, and if you're doing a big laparotomy on them, you're just compounding the factors of the comorbidity.